Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And my guest this evening is Dr. Megan Hall. Welcome, Megan.
Thank you so much, Dr. Deming. I'm really excited to be here.
Dr. Hall is a PhD, has her PhD in molecular biology from UCLA, and she is the distinguished scientist and the vice president of corporate affairs for GRAIL. And we're going to learn what the company GRAIL does, because our topic tonight is very exciting, new technology, and the topic is multi-cancer early detection blood tests. So we're going to learn about screening for cancer in a brand new way. But before we do that, let's learn a little bit about our guests. So Megan, where did you grow up?
So I am Southern California born and raised, was really a beach bum growing up, born and raised on the coast in Orange County. I've spent all of my schooling in Southern California at Santa Barbara and in Los Angeles, as you mentioned.
So where did you go to college for undergrad?
UC Santa Barbara.
UC Santa Barbara, probably one of the most beautiful campuses in the world, right there on the coast of Southern California. So what was your first declared major when you went to college?
My declared major was biology, but I will admit to having an existential crisis when I was going into college about whether I should be an English literature major or a biology major. And the very practical side of me won out when I thought about job prospects on the other side. So went the science route. But as we get into the conversation, hopefully my love for storytelling and communication has really carried me through my entire career.
So a bachelor's degree in biology at UC Santa Barbara. And then what was your next educational journey?
I went right into a PhD program at UCLA. So graduated in 4 years from UC Santa Barbara, which in hindsight, I kind of wish I had stayed for that fifth year senior because it was such a beautiful campus. But went right into a PhD at UCLA and spent the next handful of years really doing intensive molecular biology research on things like muscle and neuronal development and understanding how genes are turned on and turned off during those processes.
So even as you're applying to go to a PhD program, I mean, there's still lots of decisions you make about what the PhD program is, who you're going to be working under, what exact area of research. I mean, it seems like it would be like an endless amount of decisions to make. Do you figure out, even as you're applying to go to UCLA for a PhD in biology, who's going to take you on under their wing, or does that happen once you get to UCLA, or does it happen in the process of applying for a PhD?
Yeah, it's a little bit of both. So you apply for the programs and go through a pretty rigorous interview process where you get to meet some of the faculty and start thinking about where you might want to work on your PhD. So I had a very preconceived notion of the work that I wanted to do. By the time I got to the program, that lab had actually filled up with students already, and he wasn't accepting any more students. So I had to do a pivot. And in your first year of a PhD program, they have you do what they call rotations, which is you work in 3 different labs, one in each quarter. And then at the end of your first year, you commit to one of those labs. And so it actually ended up working out in my favor that I was able to explore some research opportunities that I might not have otherwise looked into. And that really sort of got me on the track that I'm on now.
And then most people who go through a PhD then do a postdoc where
Yes.
you work in another lab or start developing your own lab. What type of postdoc did you do after your PhD at UCLA?
Yeah, I did. Back in my day, the only real career options that people talked about with a PhD were to be a professor at a university, which is extraordinarily competitive, and there are very, very few roles that open up. Or if you don't do that, Then you do bench science in industry, like in the pharmaceutical world or in the diagnostics world. Those were really the only career options that people talked about. And I wasn't set on either. And so a postdoc really kept all of my options open. So my first postdoc I did at SUNY Buffalo, where I worked pretty intensively for a few years, trying to hide from the winter mostly, and worked in an organism called trypanosomes that cause African sleeping sickness. And so we were looking again at how genes are turned on and turned off, but in that system specifically, with the ultimate goal of trying to identify new drug targets. So that was really fun. And then after 2 years, I thought, what the heck am I doing here? I need to get back to California, where the sun shines a little bit more. And so came to UC Santa Cruz, where I did my second postdoc, also in gene expression, or turning genes on and turned off. Wow. Back in mammalian cells, looking at muscular development and how that applies to things like myotonic dystrophy or muscle development disorders.
Okay, so all fascinating things, but we're gonna fast forward. But a lot of it has to do with genes, and genes are so important in terms of the blueprint of what life is on Earth. And let's fast forward to the topic for tonight, and we'll connect it with your education and your training. But we're going to talk about multi-cancer early detection blood tests. And just a spoiler alert, we're going to be talking about that your company has this technology where in a drop of blood, you can find the remnants of DNA of cancer cells that have been shed into the bloodstream in minute quantities, but that you have the ability in a blood test to detect cancer DNA.
That's correct. And I will say it's not a drop of blood. I think that's Theranos. Yeah. Let's not associate with Theranos. Although I am wearing black.
It's a little bit more blood, but ultimately it's in a small quantity of blood that you actually can find circulating tumor DNA.
That's right. And so we actually draw 2 tubes of blood, so not any more than you would get for like your annual cholesterol test, basically. And if you think about what tumors are doing in your body, they're growing and turning over, and they have blood flow to them. And as they're turning over, their DNA is getting released into the bloodstream, and that DNA carries markers that are specific to the tumor. And so we can actually pick those up in the bloodstream. And that's exactly how the technology works, is that from this simple blood test, we are able to detect whether there is a cancer signal present in the blood. So that's a yes or a no. Do we detect cancer or not? And then if yes, we actually predict where in the body that cancer signal is coming from. And that's really important because this is a screening test, not a diagnostic test. So like all screening tests, it requires a confirmatory diagnostic workup after a positive test to really confirm that the cancer is there and where you think it is. So that location is really important to direct the next step in the workup.
Right. And so what we're not talking about tonight is another topic that we have talked about and might talk about before. And that is, let's say somebody has a history of colon cancer and they had surgery. There is a company that has a test to see after you've had the tumor removed, could you still have circulating tumor DNA in your bloodstream? And would that then indicate you need more treatment than just the surgery? So that's a really fast summary of another company. But this, we're talking about screening for cancer. So maybe let's define, what does it mean to have a cancer screening test? How would you define, like, what does it mean to do screening for cancer as opposed to do a test for somebody who already has cancer to see if they still have cells in their body?
Yeah, very different use cases. So screening is really for patients who don't have symptoms, who are just going in for example, an annual mammogram. You don't have symptoms. Basically, we're screening you to look for the presence of an active cancer. Again, that's, as you mentioned, that's very different than somebody who has a diagnosis and then you're trying to monitor that tumor or monitor response to treatment or other things. This is really upfront. Can we detect these cancers before you have symptoms, before the cancer has spread, and when they're much more easier to treat? Most cancers, when they have spread, tend to be, and that's when most patients present, when they've spread, you have symptoms. Those are very late stage cancers that tend to be harder and more expensive to treat. And so screening is an opportunity to intercept those cancers at a much earlier stage before you have symptoms.
Right.
And I'm sure you're going to ask the next question that I was just going to address.
Yeah, so what are the screening tests that we have right now? So right now, there are 5 cancers for which we have screening tests. And most people, so I'm looking at the audience here, start to think about what are the cancers that we already have screening tests for. And Megan, what are the 5 different cancers that we have validated screening tests for?
So breast cancer, of course. We have breast cancer, colorectal cancer, prostate cancer, lung cancer for high-risk smokers, and cervical cancer. Those are the only 5 types of cancer that we have recommended screens for that are part of your normal healthcare.
Right, and only one of those is a blood test, and that's the prostate cancer PSA, but it's a very different blood test than the one we're talking about tonight. It is a test for a protein that is made by normal prostate cells and by prostate cancer cells. That's called the PSA. But what we're talking about tonight is really very different, and it's a blood test where you're actually looking for the DNA of cancer cells. And again, it's screening. So it's not patients who have symptoms. It's not patients who have an active cancer. It is patients who may be at risk for cancer. So in most of the other cancer screening tests we do, the screening for cervix cancer can start at a young age, or women having pap smears once they have become sexually active. For mammograms, it's usually around age 40. For colorectal cancer screening, which is either a stool test or a colonoscopy, we used to say age 50, but now we're seeing many younger colorectal cancer patients. So we've lowered it to 45 and may actually lower it to 40. For this multi-cancer blood test, what would you say would be the general age at which one might consider doing a multi-cancer early detection blood test?
Yeah, so just one quick point of clarification that the test itself, so there's different kinds of DNA tests for cancer risk, and then this one is for actually active cancer. And so you might hear about genetic tests for like BRCA mutations or other genetic mutations. Those are your risk of getting cancer at some point in the future. This test is really about whether you have an active cancer right now. So just one kind of important distinction that I want to make.
Great distinction. Yep. That the cancer, the genetic testing of your germline is like, what genes did you get from mom and dad? And some of those genes make you more likely to develop cancer. But we're talking about actually looking at genetic material from cancer cells in your bloodstream.
That's right. That's right. So there is a clear sense of urgency with the positive test result that there is likely an active cancer that needs some kind of treatment. So back to the actual question, which was what's the intended use for this test? So age, unfortunately, is the biggest risk factor for cancer, hands down. So when you are older than 50, for example, your risk of cancer is about 13 times higher than when you are younger than 50. And so we have indicated this test for use in patients at what we call an elevated risk for cancer, which could include as something as simple as being over the age of 50. There are also other factors that predispose you for cancer. We've talked about your genetic risk, right? So you could have a germline mutation that predisposes you to cancer that would increase your risk. And there are other risk factors as well, health-related risk factors that increase is there a family history of cancer that might increase your risk? That could also elevate your risk and warrant test use in a patient that might be younger than 50, for example. And this is our indications, our recommendations for use. Of course, patients would want to talk to their healthcare provider about whether they might be appropriate for this test or not.
And another risk factor might be someone who has been treated and cured of another cancer in their
That's
lifetime. We know that someone who has had cancer, been treated successfully, been cured of cancer, that does increase their risk for having a future cancer. Unfortunately, having one cancer doesn't make you immune from having another cancer.
Unfortunately. Yeah, and I recognize, thank you for pointing that out and recognize how important that is for your audience specifically. So thank you for pointing that out. Cancer survivors are an important population that would be at elevated risk.
So again, this is a screening test. It's not for someone who has active cancer. It's not to see whether the cancer you've already been treated for has been cured or needs more treatment. And tell us a little bit about the history of how the test was developed and then some of the research that you've done that shows how it can be used in clinical practice.
The discovery itself that led to the formation of GRAIL as a company is actually quite fascinating. So hopefully your audience may have heard of non-invasive prenatal testing. This is another kind of blood test that is used to look for chromosomal abnormalities, things like Down syndrome, in obviously a pregnant woman, but it can be done from a simple blood test because there's fetal DNA in the mother's circulation. So the same way that we can detect cancer DNA in circulation, you can detect fetal DNA in circulation and use that DNA to determine whether that fetus has a genetic abnormality. What this study found, they were running this company Illumina was running non-invasive prenatal tests commercially, and published a study looking at over 100,000 women who had taken the test as part of their routine pregnancy screening. And they saw a small number of women who had an abnormal signal, but whose babies were fine. And what it turns out was happening was those women had an undetected cancer in the background that was being detected through that DNA signal. And there were different types of cancer. It was only 10 women, but they detected different types of cancer in these women. And it was the first time that they thought, we might be able to actually develop a general blood test for cancer using these DNA signals. And from there, GRAIL was spun out as a company in 2016. And we very quickly initiated some very large scale clinical studies and were able to launch this test, which is called Gallery, spelled with an I at the end, in June of 2021.
I think that's just fascinating that it was discovered by serendipity, if you will, scientists keeping their eyes open. And so you were doing the blood tests on women looking for the fetal DNA.
That's
and
right.
in the process, you found some other DNA you couldn't explain until you followed the women and found out, these women, this DNA was actually from a cancer within mom, not in the baby.
That's right.
What are some of the tests that you've done then to validate that this test as a screening test can find cancers, and which types of cancers is it more likely to find?
So one of the things that brought me to GRAIL was the scale of their clinical program and the robust plan that they had in place back in the day to support this technology. So we have what we believe is the largest clinical program in genomic medicine to date. We have 9 clinical studies that are enrolling over 385,000 patients, which is really unheard of in the genomic medicine space. The foundational studies that supported the launch of Gallery cover 2 studies with more than 21,000 participants in them. The first study is what we call case control, and that's really so we can understand the performance characteristics of the test. So we purposely enroll patients that we know have cancer and patients that we know don't have cancer, and just assess how well the test detects those patients. So that study detects those patients with cancer. I should say, how many of them? Do we get a lot of false positives? Can we predict where it is in the body? So really what we call the analytical performance characteristics of the test are assessed in that case control setting. That study was more than 15,000 participants. And we determined that we could detect a signal from more than 50 different types of cancer. So if a cancer is shedding DNA into the blood, regardless of where it is in the body, really, as long as that DNA is present in the blood, the test is pretty good at detecting it.
Megan, a quick question about that study. So I can understand the half of the patients that have cancer. How did you know that the other half did not have cancer?
Yeah, that's a really smart question. So it's really at the study enrollment. They have to, there's a clinical exam and like a confirmation that they don't have a cancer diagnosis that they are aware of. Some of those patients, of course, did go on in the course of the study to develop cancer. And one of the really interesting things that we found was some of those patients who enrolled without a cancer diagnosis but got a positive test result. So we called them false positives because they came in without knowing they had cancer. We got a positive result and they said, but I don't have cancer. Some of those patients actually did go on to develop cancer at a later point. So even some of those false positives, we're detecting that signal so early in some patients that it's really predictive of them developing cancer.
Right. Okay. Thanks for explaining that. I interrupted you, though. You were going on to say that that led to further tests then, that first test?
Yeah. So that
So to
first
show that you could really find up to 50 different types of cancer.
Yeah, so we can detect we call it a shared cancer signal. So there's kind of a general signal in the blood that's indicative of cancer that looks like a cancer signal. So we can detect that across a really broad range of cancer types. Remember, the vast majority of these cancers don't have any kind of recommended screening test right now, which means patients generally show up when they have symptoms and the cancer is late stage. So there's a huge opportunity here in detecting the more than 45 types of cancers that don't have a screening test. The other piece of information is we did this with a really, really low false positive rate. So what we don't want to be doing is shunting a lot of patients into the healthcare system with false positives and have them chase down, positive results unnecessarily and causing a lot of worry. So we purposely designed the test to have a very, very low false positive rate. And the added bonus is that we can predict where in the body that signal is coming from correctly almost 90% of the time. So if we call it cancer, we get that cancer signal origin or where it is in the body correct almost all of the time. And that's really important, again, for directing the downstream diagnostic workup to get from the positive result to an actual diagnosis. So that was our analytical performance. We followed that with what we call an intended use study. So that's great. We know patients have cancer. We had patients that didn't have cancer at enrollment. But what happens in the real world, like in a real intended use screening population with patients who don't know if they have cancer or not? So we studied that in a population of about 6,500 patients who just came in for regular screening. We actually returned the results to those patients so that we could understand what their workup pathways were when they got a positive test. And we saw a couple of things. First, that the workups were really efficient. Those positive results with the origin were very directive for the physician, got those patients to a diagnosis quickly. The other thing that we found that was really a sort of a heads exploding moment for us at the company was that the performance characteristics translated almost exactly from that first case control study to this intended use population. And that's something that you don't usually see. And usually you see the performance kind of degrade a little bit. It gets a little bit worse when you get more into the real world, into that intended use screening population. But we really didn't see that. And so that really speaks to the rigor with which we designed the test and suggests that it's going to be really broadly applicable to a broad set of populations.
So that first intended use group, I think you said were 6,500 patients enrolled. How many cancers did you find in those 6,500 that were screened, and what types of cancer did you find? Can you give us maybe which were the most common, but how many different types of cancer did you
Sure.
find in those 6,500? Because that's not a very large population.
It's not. And especially when you consider that cancer is occurring in the general population about 1% of the time. So it is a pretty low number, or looks like a low number, but it's right around what we would expect. This study, actually, I'll back up for a minute, enrolled was 50 plus. And so it enrolled 50 plus, and then we had a 50 plus cohort with additional risk factors. So 50 plus some other risk, like a genetic predisposition or a family history or something else, or a cancer survivor that was increasing that risk even more. So we actually detected a little bit more than 1% cancer in that population. I think we detected 92 cancers overall. There were 92 cancers in that population. When you added our test in, we more than doubled the number of cancers that were detected compared to the standard of care alone. So compared to those 5 cancer screenings alone, we more than doubled the number of cancers detected. So
Gotcha. And so in these 6,500 enrolled, the 6,500 got the 5 screening. I mean, the ones that they were the
they were eligible.
standard screening plus the blood test.
That's right. And that's a really important point that I want to make just in general. This test is meant as a complement to the recommended screens, not a replacement for the recommended screens. It's designed differently. It detects different things. So everybody should be getting their regularly recommended screenings anyway, and supplementing. Ideally, you would supplement with a test like the Gallery test. So, and that's exactly what happened. We had cancers that were detected. We recommended that people got their recommended screens. We had cancers that were detected through regular screening, and we had cancers that were detected through our technology. And our technology more than doubled the number of cancers that we were detecting. And we detected all sorts of cancers. We detected early stage pancreatic cancers. We detected lung cancers. We detected liver cancers, cancers that can be really fatal and tend to be caught at late stages because there's no screening test to detect them at earlier stages.
How about ovarian?
We did detect some ovarian cancers,
Mhm.
absolutely. Yes. And
So a point that you've already made is that some of the most lethal cancers, the cancers that have the lowest cure rate, aren't detected by the 5 tests that we have right now.
right.
2 that we just mentioned, ovarian and pancreas cancer in particular, there
Sure.
aren't screening tests for, and both of those are cancers that potentially could be found in your screening test.
Absolutely correct. And there is a serum, there is a test for ovarian cancer. It's a protein-based test, but it's not recommended for general use right now. And so that's just a slight distinction.
Mm,
So
mm.
there's a really cool, I'm going to just be nerdy for a minute. There's a really cool biological underpinning of the detection, the cancers that we detect. And so what we have found is that more aggressive tumors, these really deadly lethal tumors, are shedding a lot more DNA into the bloodstream, even at really early stages. And so what that means is that first, we are detecting these really aggressive lethal cancers, pancreatic, liver, ovarian, gastric, esophageal, all of these cancers that have no screening test but are very deadly, and we can pick them up at really well at early stages. That's true even among breast cancer subtypes. So triple negative breast cancer, which is really aggressive, we're really good at detecting triple negative breast cancer at very early stages, more so than the ER positive, sort of less aggressive forms of breast cancer. The other thing that's really interesting is that what the converse is that the cancers that don't shed DNA tend to be more indolent. Those are the cancers that we say you might die with and not from. So prostate cancer is sort of the prototypical example of a cancer that has been subject to some what we call overdiagnosis and overtreatment, where the treatment can have some side effects that, and it might not have necessarily needed to be treated. Those cancers don't shed a lot of DNA into the blood, which means the test doesn't pick them up as well. And so the test inherently is not subject, or we think it's not subject to overdiagnosis the same way that some of these other tests are, which is a really cool side effect of the biology that we're leveraging to underpin the product.
Yeah, and that makes a lot of sense because cancers that are more lethal tend to have a more rapid dividing, and if I understand the technology, it's not like you've got an advanced cancer that have cancer cells circulating in the bloodstream. That's not what you're finding. That a cancer, even as it grows from 1 cell to 2 cells, 2 cells to 4 cells, 4 cells to 8 cells, in the act of its natural growth, some cells die.
That's
Just
right.
like in our body, our skin
Yeah.
cells die, our lining of our gut dies. So as these cells die a natural death, they release the DNA, and that's what you find. So it makes sense that a cell that might sit in place for 2 years before it divides into 2 cells isn't going to shed the DNA nearly as much as a cell that's rapidly growing and dying in the process.
Yeah. Yeah, that's exactly right.
Um, what would be the next steps? You talked about 2 of the studies. So
Good.
kind of the fundamental study with the 6,500 patients to prove that you can detect cancer in patients who do have cancer, and then the first intended use study.
Mhm.
Where are you now in terms of the studies that you're doing to show? I would imagine you want to show so the 5 tests that we call are accepted screening tests have some evidence that by implementing these screening tests, we reduce the mortality rate, the number of people who die of
Mhm.
those cancers we're screening for. So I would imagine now you are conducting studies to try to demonstrate that if you put this screening test into effect across the population, you eventually will not just find cancer, but that you'll eventually find cancers that can be treated and reduce the death rate and improve the health outcomes of the people who get screened.
Absolutely. So we actually have a 140,000 person randomized controlled trial that we're doing in partnership with a really unique partnership with the National Health Service in the UK, where we are actually going to be looking long term at whether there are impacts on certain aspects of mortality. The issue with a mortality endpoint, so absolutely recognizing that's gold standard, and we definitely want to be able to show that this is impacting mortality or survival in the long term. The issue with that is those studies tend to take decades and hundreds of thousands of people. And because we're looking at so many different cancers, it's going to require a really big population, right? Um, what happens in that decade plus, if we wait to implement the technology or if we wait for that mortality endpoint, we lose 600,000 people a year in the United States alone from cancer. So we have this huge sense of urgency, given that we have really robust clinical validation data. We really wanted to get this test on the market so we can start helping patients now. While we work towards those kinds of endpoints. The other interesting thing to consider about mortality is that a precursor to mortality is a reduction in late stage disease in the population. So by reducing the incidence of late stage disease and shifting that detection to the earlier stages of disease in what we call a stage shift, we can see that much faster than we can a mortality endpoint. And it is by definition a precursor, excuse me, to a mortality endpoint. And so our randomized controlled trial in collaboration with the UK is actually looking at stage shift, a reduction in late stage cancer mortality, as a faster way to understand if the test is actually impacting the population. And so we're really excited about that, not just for our technology and our study, but for what it means for the whole field and technology as a whole, because this kind of technology, not just ours, moves really fast. If we wait for a decade, the technology, when the study reads out, is going to be totally obsolete. It will
Right.
have evolved. And so we have to find ways to understand safety and efficacy on a faster path. And that's one way that we can do it.
It makes sense. So the most recent of the 5 screening tests that we have that right now is the lung cancer screening test, which was shown that if and the population at risk are smokers,
Mhm.
that if you do this very low dose CT of the chest for patients at high risk for developing lung cancer, you're actually able to find very small tumors,
Mhm.
stage 1, whereas if without that screening test, you waited until patients had symptoms before you did their CAT scan, and their symptoms might be chest pain, coughing up blood, breathing issues, and then you would find a late stage cancer that was already big enough to cause symptoms. So by
Right.
doing the screening test, we were able to shift the stage.
Yes.
And what we have found is a lot more early stage cancers that are found that are curable. And that has resulted in a reduction in the death rate. But as you said, the first thing we saw was a change in the stage. And
Right.
so you're kind of using that stage shift as a bit of a surrogate for what likely would end up resulting in a reduction in mortality.
Right. That's exactly right. Yep, that's exactly right. And one interesting side note about those studies that were looking like the lung cancer studies that were looking at lung cancer specifically, the incidence of other cancers and the death from other cancers than the ones that were being screened for was actually higher than the incidence and deaths from lung cancer specifically. So it really speaks to the need for this kind of a multi-cancer test so that we can move away. We like to say move away from screening for individual cancers one at a time and screening an individual for multiple cancers. It's really how we're going to be able to do what we call bend the cancer mortality curve on a really broad population scale by detecting many more of these cancer types at earlier stages.
Right. So let's let's talk about what are some of the risks of screening tests. So for example, the lung cancer screening test, the CAT scan, it detects a tumor, but you still need to do a biopsy. So one of the criticisms, some of the people that weren't necessarily in favor of early adoption, is that some people did die as a result of having a screening test that led to a biopsy that in the very unusual circumstances could lead to death by doing a biopsy and having a pneumothorax. And in that study, some people who had biopsies who did not have lung cancer, there were actually occasionally a death. So we
Mhm.
know that screening for cancer does result in then other procedures, including biopsies, some
Right.
of which could lead to unintended uh, medical consequences, including death. The
Right.
other point I might make is that PSA blood tests for screening of prostate cancer. Not everyone universally believes that that has been a good test. And in fact, it was downgraded a bit as to whether you have to do it or
Yes.
not do it, because many men who get screened who are found to have low grade, indolent, not risky cancers end up getting treatments that cause consequences,
Yeah.
and that there's some debate over whether doing the PSA screening test actually reduced the overall death rate of prostate cancer. So
Right.
we are aware that sometimes a screening test, if it detects too many cancers that aren't medically significant, could actually cause more harm than benefit in a population. So just put that out there, because that's one of the reasons that the companies like yours that are doing these multi-cancer early detection tests, they're not paid for by insurance yet, because we're still waiting to see, is it really true that these detect more aggressive cancers, and that detecting those at an earlier time in a patient's life will improve the outcome and the overall health of the population we're trying to screen.
Yeah. Yeah. And I think so. I think that's where the beauty of the biology comes into play. Again, first we've very purposefully designed the test to minimize the number of false positives, specifically so that we can minimize that kind of exact side effect, which is really important. So our false positive rate is 0.5%. So that means out of 200 people who don't have cancer, only one of those would actually get a positive test result. Um, Additionally, we've published some data. So I'll just mention that the clinical studies that I spoke to, the case control and the intended use study that supported the launch, those have both been published. So this is all in the peer-reviewed literature. We've also published some fun data showing that the more aggressive cancers are detected much better by the assay than cancers that are less aggressive. So that's out in the literature as well. And absolutely recognizing the importance of safety. One of the things we looked at in our intended use study that was published in the Lancet was how safe is this technology? Do we see any issues from the blood draw itself, but do we also see any issues from those follow-up workups? Because to your point, we don't want to be seeing a lot of, we don't want to send patients for invasive procedures unnecessarily, and we really need to understand how safe these workups are in this kind of population. And actually what we found in that study, that's the Pathfinder study again, that was published in the Lancet, was that out of 65-ish hundred patients that were in the study, we only had 4 adverse events, and they were all due to the blood draw. We didn't see any adverse events from any of the follow-up procedures in that population. We're obviously now looking at much larger populations to make sure that that remains the case, and there is always the off chance that to your point, something untoward might happen, a pneumothorax from a lung biopsy, for example. But in our clinical data and our experience so far, we have yet to experience that.
Okay. So I can't believe our hour is we've still got time, but I want to save time for questions and answers because we've got a large studio audience here with me, and we've got people watching us live stream. But before we do, tell us, how does this work? So so right now the test is available. It's scientifically been proven. It's got all the laboratory verifications with CAP and CLIA and everything. But if somebody wants the test now, they need to pay for it out of pocket, and it costs about $949, I think. Correct me if I'm wrong on that.
The cost of an iPhone.
if somebody were to do this and get the blood drawn, and it gets sent to your company, and it comes back positive. So if it comes back negative, that's like, whoa, sign of relief.
Yeah.
Best $949 I ever spent. I feel so good. I'm just, I don't mean to make fun of this, but if it comes back positive, who tells them it's positive? And then it's like, what do you do?
What next? Yeah, really important question. So first, with a negative test result, so the test is prescription only. So you have to go through a healthcare provider to get a prescription for the test. It's not like, it's not a 23andMe that you can just order off the internet. It's prescription only through a healthcare provider. So your healthcare provider would prescribe this. We also have a telehealth portal. So you could do that would connect you with a physician that would order it on your behalf if you fill out the form on the internet. But it's all through a healthcare provider by prescription only. So with a negative test result, there is clear language on there that says still get your recommended the screens for the 5 other cancers that you're eligible for. Obviously, women aren't going to get prostate screening and vice versa, but we want to make sure that a negative test result does not preclude patients from engaging in their regularly recommended screens. So that's the first important point. With a positive test result, which again occurs only in about 1% of the population, then we have a number of resources that can help the healthcare provider and the patient navigate through the next steps to get them to a diagnosis and then to an oncologist for treatment, assuming that the positive test is correct. So we have a medical team that will call healthcare providers in every single positive case to make sure that they have the information that they need to talk to their patients. So the healthcare provider is the one that would be receiving the test result, the positive test result, and communicating that test result to their patient. So it would be a conversation with your healthcare provider.
And I assume that you've already figured out that it's not on a patient portal, that the patient's going to find out the results.
That's correct. Yes.
First.
The positives do not go to a patient portal first. They go to the healthcare provider first. That's exactly right.
So you as a company talk to the healthcare provider, not just to tell them that a test you ordered is positive, but to give them some information on what the next steps would be before they even call the patient to tell them they have a positive test?
Yeah, so we share the test result report with the healthcare provider, and then we proactively reach out to the healthcare provider. They don't always call us back. We don't, weren't always able to get them on the phone. Not everybody wants to have that contact, but most of the time we do have some kind of conversation either by email or by phone through our medical team to talk about the positive result and what it might mean. We have compiled a number of materials that are based on existing guidelines about what potential next steps might be that we can share with a healthcare provider to help them with their decision making.
So just for an example, let's say it comes back as pancreas cancer.
Mhm.
What would be your recommendation to the healthcare provider for the steps for him to take with that person who's not symptomatic, has just gotten a blood test that indicates that they tested positive for what appears to be a pancreas cancer?
Yeah. So we actually don't make official recommendations as a healthcare company. We're not the ones that should be directing the healthcare, but we can leverage existing guidelines and share those guidelines with the healthcare provider, which is exactly what we do. So we've looked at things like NCCN, we've looked at ASCO, we've looked at all of these different guidelines and compiled those materials into one place for the healthcare provider. And so what we have on that sheet reflects things in the NCCN that may include for pancreas cancer, like follow-up imaging, may include at some point, if it's a blood cancer, it may include like a PET CT, a whole body scan. And then subsequent to that, there would be an additional, probably a biopsy at some point to confirm if there is a lesion, to confirm that that is actually cancer. But those are all, just to be super clear, those are all based on existing recommendations and not a GRAIL recommendation that we're pushing.
Sure. But in all honesty, an existing recommendation on a multi-cancer early detection screening test, that doesn't exist
That's true.
until. So it's one thing to you probably have experience of the patients that you tested that had pancreas cancer. What testing did those patients have done, even though
Yes.
you weren't ordering them?
Yes. Yes.
And
Exactly.
how effective were those tests in actually finding the cancer? I would assume that some patients who get a positive result go through a workup and you don't actually find the cancer.
That
Is
does
that?
happen. Yeah, that does
Yeah.
happen. And so that would be considered a false positive. We actually have some really interesting cases where patients who have undergone some kind of scope, so like upper GI scoping, to literally look for an active cancer lesion in the esophagus and in the oral cavity. It's changed it's changed how closely the physicians look when
Mhm.
they're in there,
Mhm.
because this positive test result and recognizing that we're pretty good at detecting some of these early stage cancers, have been able to find some really sneaky lesions that they might not have otherwise seen when they go in and actually look.
Right,
So
when you're
something
looking
like
more
pancreatic
closely.
cancer is probably going to be some kind of imaging. Again, it would be based on not MCED recommendations or multi-cancer early detection recommendations, because you're right, those don't exist. But there are practice guidelines for how to follow up patients who have symptoms that might be indicative of something like pancreatic cancer. And so
Right.
that's where we're pulling from,
So
right?
I think we can say safely that usually the workup would include perhaps some blood tests,
For sure.
perhaps some imaging,
Yes.
perhaps some endoscopies of
Depending on the cancer.
upper or lower, depending
Yep.
where.
Yeah,
Obviously, physical examination
of course.
as well. And that ultimately the proof that someone has cancer requires a biopsy.
It
So
does.
you
That's
either find an abnormality on physical examination, imaging, or in endoscopy, and then that leads to a biopsy.
right.
And
That's
again,
right.
the whole purpose of this is to find cancer at an earlier stage where treatment is more likely to result in cure.
Exactly. That's exactly
Yeah.
right. Treatment with curative intent is the goal.
So we're going to shift, and I know we're
Great.
going to have another session, but I want to save time for questions and answers, and we got about 10 minutes left, and
Perfect.
they're already rushing to the microphone here in my room. So
Wonderful.
So let's keep our questions succinct as questions, not your own personal histories, so that we can get through quite a few different questions.
How many years after chemotherapy should a person get the test done? One question. The second is how often.
Let's answer that one first. So if someone is using, I've had cancer that puts me at higher risk, I want to consider this multi-cancer screening test, realizing this isn't a test to look for cancer cells of the cancer you've been treated for, but
That's right.
what would your, if we're using it as an indication a person's at higher risk, how many years should they be cancer free? Logically, what would be before you considered starting doing the multi-cancer, looking for other cancers?
We say 3 years. We say 3 years post-treatment. So that's was the enrollment criteria in our studies, and so that's what we can back up with data.
Okay. And Poon, you had another question?
Oh, go ahead.
Okay, we'll go to Gary.
I had a question with the insurance companies. You know, are they becoming aware of these tests? And as they become aware, you know, what are their reactions to this?
Yes, really important question. So insurance coverage, is going to be one of the things that enables really broad access to this technology and really does what we call democratizing access to cancer screening, makes it as accessible as possible to as many people as possible. So there are some very progressive insurance companies that are starting to cover. Traditionally, insurance companies want things like FDA approval or they want mortality data. And so we are recognizing the importance of that. We are working with the FDA we're working on getting the test FDA approved so that when it is FDA approved, we can get coverage as soon as possible.
Okay. Another question?
Yes. Are there any particular cancers that your test does not find?
Yeah, really important question, actually. So the ones that we don't detect are the ones that don't shed a lot of DNA into the bloodstream, and those tend to be the more slow-growing indolent cancers. These cancers include things like thyroid cancer. We're actually not very good at thyroid cancer. That tends to be less aggressive. Prostate cancer is one that I mentioned that also, as Dr. Deming pointed out, can be overtreated, where the side effects are actually worse than the cancer itself, and you can live for a really long time. You die with the cancer, not of the cancer.
And Dr. Hall, let me interrupt for a second. His
Sure.
question was actually, are there aggressive cancers
I'm sorry.
that aren't detected?
Yeah. Yes. So
For example, like a glioblastoma. Do you have any success in glioblastomas?
Yes. Great. Thank you for clarifying. I misheard. So there are some aggressive cancers that are not well detected. Like glioblastoma is a great example because the cell-free DNA is not crossing the blood-brain barrier and getting into circulation. So we actually don't detect any kind of brain cancers very well. And we actually we recognized that very early and ended up not including them in a lot of our studies just because it's a very different sort of paradigm for detection. One comment is that there's a really huge variation in terms of how much cancers are shedding. So a stage 1 cancer, a very early stage, might be shedding a ton of DNA. A stage 4 cancer might be compartmentalized somewhere funny. It might not have as great access, might not have as great access to the circulation. Actually, I should say stage 3, not stage 4. And so it may not shed as much. There's a really big variation. So what I'm talking about are general trends. Like it's not perfect. We don't detect everything in all the aggressive cancers at stage 1 with 100% detection rate. But as with any, no screening test is perfect. So I think that's just par for the course. I think we are quite good at the really aggressive cancers, even at early stages.
We have another question, one from our online viewer.
Yeah, a question from a viewer on Facebook. Katie wants to know if you've got any advantage in detecting blood cancers.
Oh, blood cancers. Yeah, we do detect blood cancers. Absolutely, we detect blood cancers. And really interestingly, we detect a lot So the test is really for invasive cancer, so active cancer. We also have some data that shows that we detect some of the pre-malignant hematologic conditions as well. So things like MGUS pop up every now and then. But the test reports out positive or negative for invasive cancer detection. So absolutely, we detect lymphomas, leukemias, absolutely.
And you, maybe you're just being modest, but you mentioned that you're not real good at the, the slower growing, less invasive type cancers. But yeah, prostate cancer is an excellent example. I mean, the current test kind of sucks. I mean, are you better than a PSA test?
Yeah, that's an interesting question. So I think generally we want to avoid doing head-to-head comparisons with the existing technology, just because the tests use different tools. They're designed very differently. The single cancer tests like PSA, like mammography, they're really designed to maximize the sensitivity or how many cancers you detect. But what that means is that you get a ton of false positives. And because these are directed at single organs, it's much easier to manage those kinds of false positives. So again, as I mentioned, we designed our test very differently to maximize the specificity, or really to minimize that number of false positives. So there's a little bit of a trade-off there, and they're designed really differently.
And Dr. Hall, I'm going to disappoint the audience by I'm going to do the last question myself. So I'm sorry to 10 people that are still standing in line for the microphone. But I know you didn't want to do the head-to-head comparison, but with prostate cancer, do you detect like small cell prostate cancer, the aggressive prostate cancers? Do those get detected? I don't know. Do those shed a DNA more commonly than the run-of-the-mill endocrine responsive prostate cancers?
Yeah. So to my knowledge, I'm not aware of the data that we might have that dives into like prostate cancer subtypes and aggressive versus more aggressive. But what we do have is more general data and data in other cancer subtypes like lung cancer subtypes and breast cancer subtypes. So analogous, where we know, and then in aggregate overall, we know pretty definitively and have published that the cancers that we detect have a much worse prognosis than the cancers we don't detect. So
Gotcha.
if we're detecting your cancer, it's an aggressive one. So
Okay.
even if it's within a cancer like prostate that tends to be more indolent, if we're detecting it, it's probably warrants treatment.
Well, Dr. Megan Hall, our guest tonight, we definitely will have you back. Dr. Hall is the Distinguished Scientist and Vice President for Corporate Affairs for GRAIL, a company that makes the test called Gallery, that is a multi-cancer early detection blood test. So thank you for being with us, and we definitely will have you back again. For those of you watching this live streaming, if you know someone that would benefit by watching this program, it will be available tomorrow on the Above and Beyond Cancer YouTube channel, and it will also be available on the Mercy Cancer Center website. I hope you'll join us again next week. Thanks for being here.
Thank you so much.